Good afternoon, everyone. This is Kaylee with CCALAC. We're going to give it till 5 after to allow time for more people to join. So hang tight. And in the meantime, if you want to take a look at the handouts, we have 3 handouts that are listed under the handout section of your GoToWebinar browser there. So go ahead and get those downloaded if you would like, and we'll start in about 2 more minutes. All right, everyone, we're going to go ahead and get started. Again, this is Kaylee from CCALAC. Thanks for spending your lunch hour with us to talk about AFS, or Advancing the Financial Strength of Los Angeles County Clinics. Just a quick thank you to LA Care and Cedars-Sinai for the support of the AFS program. A couple of save the dates for you all. AFS 200 series is going to be on March 22nd and 23rd. That's the 2 full days of training plus the board dinner on the night of the 22nd. And that's going to be at the center at Cathedral Plaza, so you can mark your calendar for that. And then we'll also have AFS 250, which will be a smaller training on revenue cycle management. Is going to be April 17th at CCALAC. And if you're subscribed to get the emails about trainings, those will all come to you when registration is open, which will be very soon. A couple of logistics for today before we dive right in. Everyone's going to be in listen-only mode as participants, but please feel free to type any questions you have into the question tab of your GoToWebinar, and I'll be sure to pass those questions along to Susan and Jonathan. And we also have 3 handouts for you in the GoToWebinar browser, so you can see those. You just click to download. And I'll be sending out those handouts as well as the PowerPoint presentation as a follow-up email as well. And I think those are all of the reminders and logistical pieces that I have for you. And with that, I'm going to hand it over to Susan and Jonathan.
Thank you, Kaylee. My name is Susan Petrie. I'll be starting us off this afternoon. I guess it is afternoon there. I'm coming from Boston, and Jonathan is in our Colorado office. We're pretty spread out throughout the country. I'll start, and then I'll hand it over to Jonathan. So just a couple minutes about us. I think many of you are familiar with Capital Link. I am the Chief Operating Officer, and Jonathan is the Director of Community Health Center Advisory Services. I don't know what's the best way to forward it, Kaylee. Should I just tell you, or? Okay, thank you.
I'll try to be intuitive about it, but if I don't move it, just let me know.
Okay, just let you know? Okay, great.
Yep.
And thank you for coordinating, Kaylee, because we are in different offices. Much appreciated. So just a 2-minute overview of Capital Link to let you know where we're coming from and our role in the industry, as well as with this project for CCALAC. We were launched about 20 years ago. We're a national nonprofit, HRSA National Cooperative Agreement recipient, and we do have offices in 7 states. California is by far our largest market, and we have Colorado, where I just mentioned Jonathan is, Massachusetts, where our headquarters are, Maine, Missouri, South Carolina, and West Virginia. So we're pretty well spread out around the country. And we have to date, since inception, done about a little bit over $1 billion in financing for community health center capital projects, about 225 projects, and a very good number of those in California. So we're very familiar with community health centers and with the California market. And basically we do 3 key things. We provide direct assistance to health centers and basically those that support health centers, particularly federally qualified health centers. So PCAs, consortia, and others, foundations and others that are helping health centers in terms of sustainability, capacity building, operations. We provide industry vision and leadership, so we come up with strategies and numbers and information for organizational, facilities, and operational and really financial improvements, which is our forte has always been in the finance area, but also operations and some clinical as well. And we provide metrics and analytical services in terms of showing health center impact, trying to show what the trends are for health centers in terms of financial trends, operations, and really trying to focus on performance, promoting performance improvement. And that's really where the whole Advancing Financial Strength program came about. Go to the next page, Kaylee. Are we stuck? Hello?
Yeah, are you, I'm on the Advancing Financial Strength slide. Are you seeing that?
There, now I am. Thank you. I apologize for that. Yeah, it just came up. I guess it's a little delay.
No problem.
So, so the Advancing Financial Strength program was originally developed about 3 years ago, and it was intended to be a 1-year program. We created it with CCALAC, working very closely with the consortia as well as the members to put together tools, trainings, and technical assistance, basically to help health centers grow and be financially sustainable. And the thought was that it would not be a typical CFO training program, but instead have people from all parts of the organization working together and basically an integrated learning experience. So it wouldn't be a one-off training where you kind of come to a training and then you just go back, or a training where you work with, you know, all of your peers that are dealing with the same kinds of issues and maybe coming from the same perspective, but can't relate to others in the organization. So we really wanted to bring in, the initial concept was to bring in the C-level people in the organization, so the CEO, COO, the CFO or head of the finance group, the CMO, and board members, as well as the teams. So the finance team, the clinical team, and really have people work together and start using a common language, and to understand that financial sustainability is the responsibility of everybody in the organization. It's not really just a CFO responsibility, and to focus on how organizations can improve operations, understand the finances, understand the key drivers, and work together to affect change. And so the overall goal was being able to provide access to high quality care. And in order to do that, we need to be financially sustainable, keep the doors open, essentially. And so when we first started out on this a few years ago, there was still very rapid growth throughout the country. There's still fairly rapid growth in California. Some of the other markets have slowed down quite a bit, and California has certainly slowed down over the last year or so after the huge gains we were all seeing and the big dictate for growth. But we really see this as an integrated program. So as we're going through this information, you'll be hearing a lot about kind of the financial aspects of things or the financial considerations or implications, but it's with the understanding that it's all based on providing access to high quality care and that all of this is interrelated. So the program itself talks about staffing, productivity measures, utilization, and all in the middle is the improved access and financial sustainability. So we're also working in the AFS program overall, showing clinical outcomes, increasing patient satisfaction, improving financial operations. So it's all interrelated. This particular program that we're on today is really focusing on benchmarking and dashboards and understanding kind of the financial side of it. But it's all part of a bigger program. So in terms of how the program's structured, I know several of you your organizations are new to it, and in some cases you individually are new to it. So I just want to spend a few minutes to kind of help you understand what we're trying to accomplish and what the different components are, so that you can best understand where to plug yourself in or to recommend to other people in your organization who might benefit the most at various points. So basically the whole idea a few years ago was to increase financial sustainability and readiness for growth. As we talked about, that slowed down in terms of physical growth, but there's still a dictate and a need to increase access. There's still a lot of change going on in the industry in terms of payment reform and the need to better understand cost structure and increase efficiencies and making sure we're doing more with what we've got, essentially. So the first step in that is understanding. So looking at assessments and training on metrics and benchmarking and improving efficiency. So today's program is part of the whole understanding aspect of it. And really the first part of all of that is putting together performance evaluation profiles, which most of you, I think, on the phone have received. We produce those for any organizations that provided financial information, their financial audits. In many cases, we already had them, but for those that did not, we put together that information and the UDS information and combined and analyzed the data and compared it to each of the health centers. Information was compared to the consortia overall as well as to California overall on about 70 metrics, including the first several pages that were more of a dashboard looking at charts and growth rates. And I hope that all of you have seen that report. If you have not, they were distributed to the CEOs and CFOs in your organization. And if you're interested in seeing it, please ask them. We're very much of the opinion that the information should be shared throughout the organization. And hopefully, if you haven't seen it, you can ask for it, and we'll hopefully have access to it. But that gives a good perspective on how you compare to others. And are you in the middle of the pack? Are you in the top performers on various categories? Are you in the bottom on others? And the intention is to give you an idea of where the strengths and weaknesses in the organization. And we found that that's been tremendously helpful for people because sometimes you just don't have a basis for reference. And so a few years ago when we started this up, there were not a lot of comparative metrics and information available for this group overall, for the CCALAC group. Now the majority of the members all participate in the PEP, we call it the PEP Performance Evaluation Profile. They're sharing the data and seeing it for their peers in aggregate. So it definitely isn't shared, like we're not showing one health center what another health center looks like. Your information is private. If you want to share it with somebody else, you can. But the way that we keep it is that it's shared with CCALAC if you signed a document allowing for the sharing of the data. But other than that, it's really just your own information compared to your peers. And we do share the overall information for the consortia with everyone, so you can see how the consortia has changed over time. So that's the first step, is really understanding. So the PEP reports provide some information, this kind of training that we'll be doing today, some trainings we did in December, which will be somewhat, some of that will be repeated or built upon on the March training that Kaylee referred to. The second part is developing action plans, and that's basically taking the information that you have and moving forward with it. And what are some of the training and strategies for improving operations, either through peer learning, through training programs, through more information. What can we do to help? And we found that there's a number of areas where there, everybody or a very large portion of the group needs help in specific areas. Revenue cycle management is certainly one of them. Another one is productivity enhancements. Another one that's come up recently is in terms of kind of cost management, understanding your cost structure. So that's a new program we're working on in coordination with CCALAC. Change management, all of the team care models and evolution there. So those are all categories that many of you find helpful to learn in a kind of group setting, working with your peers, working with experts, including Capital Link, as well as our partners. We do not know everything, of course, but what we try to do is for those areas that we're not as, do not have as much expertise on, we bring in experts in the industry, and that's proven very successful. The last thing is implement and monitor, and that's providing individual technical assistance and support. So basically taking what you've learned through the reports, through the trainings, in person and in webinars, and figuring out what you need in your individual health center to be successful. And we're very fortunate in the LA area with the generosity of the funders that there is money to support some individual one-on-one technical assistance. So that's been extremely helpful, taking kind of the theory and the implementation from training programs and putting it into practice in your actual center. So how are we doing? As I mentioned, the program's in its third year. We're delighted. When it was first started, we didn't, know. We were working closely with Louise and Lisa and others at the consortia. We weren't sure how many people would participate or find it helpful, and we've gotten really great reviews, and mostly what's been successful is hearing from the centers in terms of what's most useful for you. And we've developed the program and continue to update the modules based on what's most helpful for the participants. And so that's been really great. And some of the information continues to be very important. Some of it is less important or interesting to people. And, folks have mastered a certain thing because we've been doing it for a couple of years, and we're on to the next thing, or what's the most important thing right now. So we've tried to evolve over time. Almost 40 health centers have participated to date, which is a tremendous turnout. And by that, by participating, that means really coming to programs, participating in terms of sending information and data. Over 500 different people have come to one or more of the AFS training programs, whether it's in person or webinars. I actually think it's probably quite a bit higher than that. It's hard for us to completely judge sometimes, but sometimes one of our consultants will go out to a health center and 15 people will sit in the program, or more, and we can't always count that. But a lot of the folks that are involved in this take advantage of all of the opportunity and come to many of the programs, or they've come to something and then they send somebody else in their organization and say, oh, you should really sit in on this. So that's been very fulfilling, very helpful. About 150 of the PEP reports, the performance evaluation profiles, have been completed for health centers and for CCALAC. And over 25 health centers have received hands-on individualized technical assistance and coaching. There's been a great commitment to really wanting to improve, to listen to what peers are doing, to listen to what other people around the country are doing well, and to talk and to share expertise in kind of a trusted forum. It's been really fun for us as national consultants. We work all over the country, and I initially thought when we came into work with LA, I thought, well, how open are people going to be to sharing? It's a relatively small geography, although I know you guys don't think that, going from space to space in the traffic. But it's been very heartwarming to see everybody's willing to just share ideas and understand that together we can build something stronger, and that there's a lot of opportunity and a tremendous need for access. So it's been really great, the ability to share and the openness in terms of best practices. So I just want to reiterate some dates that Kaylee mentioned. The March 22nd and 23rd date is our third year of our, kind of big spring conference. We've done it the last 2 calendar years in March as well, and it's basically a 1.5-day in-person training this plenary and small group training, breakout sessions. I can't stress to you enough how valuable this is. You can, if you're able to come or others in your organization are able to come, one of the things I love about this program is it's open to everybody, basically at all different levels in the organization. So, and there's a lot of support from the C-level suite in terms of sending people. We have board members there, which is fabulous, getting their perspective, working with people from other health centers that are perhaps in a different area than yours, so CFOs talking to CEOs. It's fabulous to see the CMOs and the CFOs talking to each other. Sometimes they're from different organizations, and it's just really some great connections. So we've learned a lot from those in-person programs as well, hearing what your challenges are and what your solutions are. We share what we've learned in other parts of the country as well. So if you're able to go to that, you'll be getting more information from Kaylee and Lisa Fisher. We anticipate doing a program on metrics that matter. We'll be doing benchmarks and best practices. So even further into some of the information we're discussing today. We'll definitely be doing programs on team-based care and change management. We have a couple of people that have done those presentations in the past. They're great. We'll also be adding, down the bottom of this is project management. That was a section that was requested. So I think that will be a nice addition this year. We have revenue cycle management, which for that program will primarily be more of a top-level strategic overview, because most of these sessions are going to be about 90 minutes in length, kind of a typical length where there's, 60 to 75 minutes of presentation and then 15 minutes of questions. So there'll be a revenue cycle management aspect, some productivity enhancement sections, and we're talking about some other ones. So I know that you guys get surveyed recently or often, and we really welcome your feedback as to what's most important, what would be most interesting to you. So I think you'll be questioned in the next couple of weeks again, like, does anything really resonate with you? What are your real issues? We may have a cost of care segment in that program, or we may not. So it kind of depends on how much time there is and what the priorities are for the members and for CCALAC. We have all of these different areas of expertise that either we have and or we can supplement. So we'll bring those folks in. So that's our plan. And then whatever isn't covered, kind of in that 1.5 day program, we tend to do, I'm sorry, can you just go back for 1 second? Yeah, so whatever isn't covered in the 1.5 day program, we tend to do a bigger 250 series program. So March 22nd and 23rd, it doesn't really matter to you guys, but that's called the 200 series. The other ones, like where it says April 17th, 2018, that's a full day training program on revenue cycle management. And that's a great program too. It's really taught from a strategic perspective in terms of how all of the different aspects come together. So it's not really for like a CFO, although they'll find it interesting and the finance department will find it interesting. If any of you are interested in how the whole kind of patient cycle and flow and everything comes together, and where all the processes work and how important it is to come together as a team, I'd recommend that program as well. Other things coming up in calendar 2018, we'll be doing more in-person webinars and some training programs. As I mentioned, those topics are to be determined by the members and CCALAC, so definitely speak up and send along your ideas. And we'll be doing ongoing individual health center technical assistance support and coaching for approved projects. I do want to point out, it says the next line in red, grant applications due for individual health center technical assistance on February 2nd, which is tomorrow. The consortia has extended that by 1 week, so if you're interested, you have till February 9th, a week from tomorrow. One of the handouts that you received, and that's in the right-hand side over there, is an application for AFS 300 series work. It could not be simpler in terms of applying. It's just, writing a few sentences on what would be helpful to you to apply some of the concepts that have come up during the training programs for AFS. If you are a returning center and received technical assistance in the past, you're eligible for a 50% match. If you are a new center that has not received technical assistance in the past, you're eligible for up to 100% up to $10,000. So there's some, more information on that particular application, and Jonathan at the end will also just kind of wrap up with some of that. But I do encourage you, you know, the very generous funders in the state, and would really love to be able to work with each of you or individually to the extent that the funds are available. So if there's a project you've been wanting to do, ranging from financial modeling to a little bit of strategic growth planning to change management to revenue cycle management, there's many, many topics that we can address and help you with. So jumping ahead to some of the concepts now, we're really talking a lot today about benchmarking, and it is interesting to think about kind of the origin of where that term came from. It helps us kind of put things in perspective. So it comes from that little, you can see the little picture on your computer there in terms of the horizontal marks that surveyors made. And it could be placed to form a bench for a leveling rod. So you can see the little geological survey on the left-hand side, but it was one definition is a surveyor's mark cut in a wall, pillar, or building, and used as a reference point in measuring altitudes. The second one, and really what we're talking about today, is the standard or point of reference against which things may be compared or assessed. So you'll hear me talking a lot about benchmarking and comparisons and so forth, and that's really what we're doing. Like what's the median, what's the top quartile, what's the bottom quartile, good, better, best. That's kind of what we're referring to here. So the idea is think thrice, measure twice, cut once. So you've got the measuring tape, and then it says the cutting's more fun than measuring. But I love this image on the right-hand side now. Here you can see, you know, the stairs and the ramp, and, you know, I don't know what's going on there, but this is like a for real picture of something that shows when planning and thinking and coordinating isn't done correctly, this is, you know, what results. So we're talking about benchmarking within managing. So there's, you know, several steps to it. So we're referring to, and, you know, kind of the discussions this afternoon about tracking. First, you have to track, because if you don't track things, you won't know what the numbers are. Then benchmarking it. You know, you got to compare it to something, whether it's yourself, whether it's others in the industry. Like, how are you deciding what the relevant markers are there? Monitoring it, and then adjusting. So it's, you know, it's a cycle. So you're reviewing, you're revising, and then there's a reward if things go well. Having some kind of positive feedback loop is really important. So benchmarking, dashboards, and updated trends. The whole idea is, you know, figuring out what does success look like for your organization or your department or, you know, whatever you're responsible for. And basically, you can't manage what you don't know, and you can't know what you don't measure. So we have at Capital Link are using the, you know, famous wisdom triangle, which I think many of you have probably seen before. But I do think it bears some talking to, because, you know, you hear a lot about data-driven decision making, and we need data, and it is important that we think about that in terms of kind of a continuum, and, you know, what are we trying to do with the data? So if you look at the bottom, it's like, okay, we've got a bunch of data, but on the right-hand side it says big nulls, no nothing. Because the data in itself isn't really necessarily helpful. But if you add, I mean, we all get way too much data, and it's hard to know what do we want to pay attention to, and what are we going to prioritize, what does it mean, what's the so what factor. So as you can see on the left, given context, it becomes information. So if you have data and you have something to compare it to, you know, to give it context, it becomes useful, organized structures, and it's more useful and helpful to you for things. Then if given meaning, it becomes knowledge, contextual, synthesized learning. And then given insight, it becomes wisdom, where you can actually take some action steps. You understand it, you know what it means, you know the implications, and you can move forward with it. And that's been one of the intents of the AFS program overall, is to get the data, put it into context, and be able to actually do something with that information, understand what it means, and then take action accordingly. So when we think about benchmarking and best practices, it's important to first think about, what do I want to track? If I'm a CEO, I might want to see certain things, whereas if I'm a clinical manager, I might want to see other things. And then where do I find the data? We all get loads of data for our internal operations from many different sources. It can be overwhelming, but sometimes you want to know, well, how do I compare to other health centers that look like me, or other health centers in my market, or other health centers in my state? And there are some sources of that information. We'll talk about that in a second. Which metrics do I need? There's only so much bandwidth, so much time for me to track this information. What do I really need to pay attention to? The fourth thing is, how do I analyze it? I look at these numbers, but don't have any idea what they mean, and, help me put some understanding behind it. And the last thing is, who needs to know? What should I be sharing with whom? What are folks interested in? So, in terms of thinking about performance dashboards to look at, to do some benchmarking or to provide some context for your analysis, the first thing is to identify your target audience. Dashboards should be customized for who wants to use them. And, board members are going to want something different than executive managers versus clinical managers. So there may be some overlap, but clinic managers, for example, will want a lot more data about cycle times and appointments and those kinds of things, whereas board members might be looking more at top level, how are we doing? Are we making our revenues and bottom line figures? Are we able to keep the doors open? Are we meeting our overall patient goals? And they're not so concerned about a day-to-day basis for patients or hour-to-hour basis. Then choose your financial and operational metrics. Limit what you're tracking. 5 to 10 metrics. Our Capital Link's overall top-line data dashboard includes 15 metrics, which is a little bit high, but we consider there's like 5 or 6 that are absolutely critical, and then the next 8 or 9 most people in the organization will want to see as well. And really stay consistent with your ratio definitions and calculations. We will provide, and if you look at, we provided you with the benchmarking toolkit, the California Performance Benchmarking Toolkit. This page is actually from that toolkit. Within that toolkit, we have a number of ratio definitions in the formulas. So I encourage you to look at those. Most of them are very standard. There's a couple where, folks will say, well, we do it this way, we do it a little bit different, and that's fine. As long, if you're looking at yourself over time and you're tracking it the same way, that's fine. And you can still compare to, the majority of Capital Link's metrics, but just bear in mind that yours might be a little bit different because you do it a little bit differently. The third thing is to match your reporting objectives to your available data sources. So the annual data is often the most reliable. Probably the most reliable data are the financial audits, which come out annually and are audited from an outside firm. So you know that that data has been looked at by somebody outside the organization, CPA, they've gone through it, it's very accurate. So it's really, great information to use, but it's old. So that's the downside of having that really accurate data. UDS data, as we know, is self-reported. It's not perfect, but the nice thing about UDS is that you can, you can see and compare with other organizations. Same with the audits, like working with Capital Link, or, we have the financial audits in the UDS, so we can put all of that together. So it's a nice basis of comparison. Where, if we had perfect numbers that were audited or were reviewed for UDS, that would just be just so time-consuming and expensive that it's just not possible. So using audits in UDS is pretty reasonable. OSHPD's great if you want to look at site-level data. So there's some really good annual sources, but the one downside to them is the time factor, that they're a little bit dated. If you want to make some more real-time decision-making to determine how are we doing right now, are we on track with our monthly or quarterly goals, how are things going on a more regular basis, then you want to use, your PMS system, your interim financials, other internal reports. But, bear in mind that, interim financials are not going to necessarily be 100% accurate. They should be if your financial team's doing a good job, which I'm sure most of them are, but just in terms of independent financial analysis and audits, the annual audits are, the externally generated annual audits are clearly ones that we can all stand behind. And then explore your available reporting tools. So people, I think, get very caught up in, we need dashboarding software, we need this new system, we need to include every statistic, where do we even start? The CMO wants this and the CEO wants that. So start simply, especially when you want to be looking at things across organizations, across divisions or across the organization. So that's why we've come up with some really basic top line metrics that are really important, and then you can start digging into them more at the individual division level as well, department level. But Excel is very simple. You can do some really basic stuff in it and look at some, you spend a little bit of time setting it up, and then it's really quick to update regularly. I mentioned the Capital Link Benchmarking Toolkit. It is on Capital Link's website. It's available to you free of charge as well that way. But you do have the download on the right-hand side, and Kaylee will be sending it to you as well. And it is a really good resource. Some of the financial metrics, some of the key metrics that we look at and we want people to understand are listed here. I would say these are 8 of the top 15 that we look at regularly. Jonathan will go over a few more when he comes on in the second half of the discussion. But the few that are really critical are operating margin, bottom line margin, personnel related expense, days net patient AR, and days cash on hand in terms of financial metrics. And there's a reason for that. Like, those will quickly tell you how well the business is being run. Are you in good shape? Are you, is your situation liquid? Are you in dire financial circumstances? What's going on some key factors. And if things are off on any of these 5 statistics, then if they look funny, then that will prompt you to ask some additional questions. And these are the metrics that certainly the board wants to see, the CEO, the CFO, and I would argue that the CMO, COO, and others in the organization really need to know this information as well to understand the challenges and opportunities. So I will in a minute talk a little bit more about some of these formulas, but I also do want to talk about the productivity measures, which would be physician, mid-level, dental productivity, and other items like that. Productivity right now is still the basis for revenue generation for the majority of community health centers. As you know, it's still a volume-based business as opposed to a value-based program, which we're moving towards. So Jonathan will talk a little bit more about that evolution as well shortly. But right now, still under PPS, productivity is the basis for revenue generation. So we are still, Capital Link is still tracking information in terms of visits as well as patients. And we're saying that because of this kind of transition period, it's important to track productivity both ways. So just kind of keep that in mind. But looking at the top in blue, the items that we've pointed out, the operating margin really is a measuring stick for your business. Margins are typically small in the health center business, but they need to be positive, or you're not going to be able to keep your doors open. We've typically said that a 3% margin or as a minimum is a good goal for a health center. We tend to not be very financially lucrative places of business. So a minimum of 3% is usually important, but you'll see in a moment that the trends have been even more positive than that, particularly with the Medicaid expansion. The bottom line margin is similar to operating, but it's looking at things that are not necessarily part of your operating model. So as you know, most health centers get the majority of their revenues from net patient service revenues. They get some grants, but from time to time they'll get they get operating grants as well. and that all counts in their operating revenues and their operating margin. But from time to time, they'll get kind of one-time items. They may get a capital grant. They may sell a building and have a positive cash inflow from that, or other items that are really not as related to their day-to-day business. So that's what the bottom line margin will show. So if you've had a positive, capital grant or something coming in, it will show a bigger bottom line margin than operating margin. The operating margin really is showing how your business is running, how the health center itself is operating on a day-to-day basis. So it is more important on a long-term sustainability basis. The personal related expenses, that's obviously the hugest part of the budget. It usually consumes about 70 to 75% of all costs, and it's really the key driver of financial performance. We see almost a direct correlation between high personnel costs and negative operating margins. So I'll talk about that in a moment. And then the other two are the days net patients accounts receivable and the days cash on hand. So financial management really starts with collecting your money efficiently. And if you have a large number of days in the accounts receivable, that means your cash on hand is probably pretty slim and could impact your ability to pay the bills, to make payroll, and to do other activities. So the goal is always to keep patients AR at a minimum and days cash on hand at a maximum. So you want to be collecting your money efficiently and effectively. That's very critical. So I'm certainly not going to go through all of the metrics, but I did want to just point out a few. And as I mentioned, all of these calculations and formulas are in the benchmarking toolkit, and we will also be going over some more of this information more when we're out in March in LA, and certainly available for any questions. But I did want to point out a few, just because these are three critical ones. So, for example, the operating margin is the change in net operating assets over total operating revenues. The personnel-related expenses, this is one we get questioned on a lot, is we take salaries and related expenses, add in fringe and payroll, add in professional, contract, and consulting, and all of that together is divided by total operating revenues. Some organizations, some health centers, the only question that comes about is, well, I don't know about professional, contracted, consultants, because sometimes some of those are like kind of one-time fees, but it's really the only way to do it, because there's so much of the revenue of the salary structure can be allocated to some of this consultant and contract work. It's really critical to include it. A lot of health centers use a very large percentage of contractors. So just for consistency across health centers, that's what we do. But from time to time, people will say, well, we don't include such and such in ours. And so then if that's the case, then your personnel-related expenses might look particularly low when you're looking internally. And then you'll say, well, why does Capital Link's numbers look bigger than ours? That's why, because we're including the professional contract. And then the days cash on hand, it's a simple formula. It seems confusing, but it's basically your cash, and then you take your operating expenses less depreciation, your annual operating expenses less depreciation, because you're not paying that out, any kind of depreciation. And then you divide that by 360 days. So it's basically saying, okay, if we do that, how many days cash do we have right here, right now, in case for whatever reason, business slowed down, or we weren't getting reimbursed, or something changed in the industry. So those are really important metrics to be keeping an eye on. So I thought it'd be interesting to show, some ranges and just some trends, just to give you an idea of, where things are going for CCALAC compared to California overall and to the national median. And then I'll also just show a few statistics of CCALAC versus California. So this is looking for 2013 through 2016. The next several charts will be similar. And we have blue is CCALAC at the median, green is California overall, so that's all FQHCs in California, and then yellow is the national median. So I'm really happy to report that California is doing very well. The industry overall, the health center industry overall, has increased. You can see that the national median, the yellow, in 2013 was 1.1% operating margin. In 2016, it had jumped to 4.4. In California, it jumped from 2.1 to 6.5. And for CCALAC, it went up from 2.8 to 6%. And we all know much of this, particularly in places like California, has been driven by the Medicaid expansion, and certainly a lot of the national numbers as well. I guess onto the next page, please, Kaylee. That's the operating margin. The other key metric that I told you to keep an eye on was the personnel-related expenses. And you can see here, it's a little bit confusing. I apologize. The numbers are kind of tight together, the way that we set it up, because we have 0 to 80. But pretty much everyone here does CCALAC, California, and national have all hovered in the 69%. I think the most was 74%. So within a 5-point range. But there's a direct correlation, as you saw above, when we had higher personnel expenses in these earlier years, as 2012 and 2013, the operating margins were less. In 2016, when we have 69%, 70% personnel expenses as a percent of overall, the margins are considerably higher. The days in net patient receivables, you can see, has consistently come down. So it was 60 days for CCALAC in 2012, and it's down to 48 in 2016. So it's still higher than its peers, but it has dropped pretty significantly. The overall Capital Link benchmark, and it's also on the other pages too, there's some benchmarks, is 60 days. You can see that gray line. And we have stayed, California's basically stayed, CCALAC has stayed below the 60-day line and has dropped. So that's really good news. And then the days cash on hand, which moves in the opposite direction of the days in accounts receivable, has consistently increased over that time period. So that just means that overall the industry has become more sophisticated at collecting its revenue, collecting on its receivables more quickly, managing financials more effectively, and that's going to be really important, particularly with all of the potential industry changes coming down the road. So again, you can see in 2012 that CCALAC had 38 days cash on hand. It was up to 56 in 2016. Still quite a bit below California overall in the national median. That's actually something we've been working on, and you'll see some really nice improvements there. But nicely ahead of the 45 days minimum that Capital Link recommends. The physician visits per physician FTE, interesting that CCALAC has consistently been above its peers, and we're happy to report that, and you can see that in 2015, CCALAC started to uptick, where its peers in California and nationally continued to go down. We feel confident that a lot of the work that the health centers have been doing here in LA on implementing some of the ideas from AFS and some other performance improvement techniques have really helped there. Same on the next chart, you'll see the mid-levels have a similar trend line. Looking at some of the growth rates, you can see the patient growth for CCALAC continues to be quite a bit higher than California and the national. So it grew at 9% still in 2016. After a couple of softer years, we had a huge uptick and then a little bit slower growth. But yes, a nice growth in patients. And then the next one I think will show the growth in, will show the change in the insured patient population. And this is a really fascinating chart and explains a lot of the improvements in margins, the operating margins over the last few years with the Medicaid expansion. So you can see in 2013 that 45% of patients in CCALAC were self-paid, uninsured. In 2016, the number was 27%. And the Medicaid patient population basically went from 47 up to 64. So that was a flip that we're all aware of. But it's just interesting to see the actual numbers here, which you may not be aware of. So it's a good point of reference. Also interesting to note that how much, and we all know this, but how much of the actual revenues collected come from Medicaid. So 85% of all collected revenues for patient revenues was for Medicaid in 2016, a little bit less than in 2015, but very clearly a huge percentage, very, very important. And we tend to use that information, like when we're working with CPCA or Consortia or others, to just show how important this revenue stream is to California health centers, and how any disruption in it would really have a very negative impact on the organization. Median growth rates in visits has also been fairly high at 10%, a little bit higher than for California in the national median. And the last bunch of information I'd like to go over before handing it over to Jonathan is to just talk a little bit about, showing some of the improvement that we've actually seen here in LA as part of the, during the AFS programs that have been implemented over the last couple of years. Because obviously one of the things the funders are looking for, and we want to evaluate ourselves on as the CCALAC, is it working? So here's some numbers to show where we've seen some changes and improvements that we're really very proud of everybody's hard work. So what we did was we looked at CCALAC in FY15 when we started the program, and in FY16, which was a year in, or I guess about a year in, a full 15 months or so into the program, and we looked at CCALAC, California Metro, and California FQHCs to see on some of those key metrics that I talked to you about how things had changed. And the reason why we included California Metro and California FQHCs was we knew that everybody had done better in California because of the changes in the Medicaid expansion. So we didn't want to say, well, yes, the LA centers are doing so much better on all of these factors without accounting for the fact that there were some outside industry and market changes. So we kind of tried to have a control group of California Metro, which is San Francisco, a combination of San Francisco and San Diego health centers, and then all California FQHCs. So it's really interesting to know that in FY15, CCALAC's median personnel-related expense was almost 73%, whereas California Metro was 71%, and California FQs were just over 70%. On the other hand, a year later, CCALAC had dropped 4 points to just about 69%, while California Metro went up a point, and California FQHC stayed pretty much flat. So that's really good progress. And the result was a really big jump in operating margin for the LA clinic. So they went from a median of 4.1 up to 6.0, and then for California Metro, it went up, 0.7 points, and California FQHCs went up 1 percentage point. So while CCALAC was actually behind its peers in California Metro, so San Francisco and San Diego combined a year ago, now they're a little bit ahead, still trailing California overall, but Louise and the consortia felt like the best comparative group was California Metro. So we're really kind of paying most attention to that, which seems like the groups that are closest to yours. Days cash on hand and days in patients receivables. You can see cash on hand went up. Days in that patient receivables went down for CCALAC. So that's encouraging news. Physician productivity, you saw that on an earlier chart, which looked at the trends. For LA, it has consistently been higher over the last few years than for California Metro and for FQHCs. And an interesting dynamic in FY16 was that it went up for LA and went down for Metro and California overall. Same with mid-level. You can see the increases in LA, slight increases in California Metro and California overall, but LA continues to be more efficient if you're just taking the formula that we discussed, the physicians looking at the visits. The one area where we did not, the only area where we did not see improvements at CCALAC or better performance in LA compared to its peers was in dental productivity, and we have not addressed dental productivity in the state. I'm sorry, in the region. LA has much fewer dental visits as a percent of overall visits than its peers in both metro and across the state. And it's something that's being looked at in terms of understanding capacities and needs. And we're also, I think in the next round, in fact, I think in the March training, we will be having some initial discussions on dental integration, things to think about and consider in terms of, should we integrate dental? What are some of the questions to ask? What are the costs? What are capacity issues and so forth? So anyway, I did want to include this because I did want to point out that the dental kind of variance with the peers in Metro and California FQs. Another thing we look at, as I mentioned to you, is we're looking at patients on a visit basis, and we're also looking at medical patients per provider and per medical staff. And these are really interesting, again, to show that on a per provider basis, LA increased nicely over the last year and is fairly well ahead of its peers at this point. And in terms of the medical patients per medical staff, we've also seen nice improvements there where we've seen a little bit of a drop-off in California Metro and FQs. So it appears that the focus on those activities and the training and the efforts of the individual health centers to implement some of the ideas has really paid off. Another thing that we're seeing is that the non-provider medical staff per medical provider in some health centers seems to have a little bit of a correlation to efficiencies. So sometimes it appears that having more of these non-provider staff members per provider can be an effective and efficient model. I, of course, want to point out that that's, depends on the model and the health center and so forth, but we've been trying to track this as to see if we see any correlations. So there has been a slight uptick there in LA. And just again, summarizing the patient and visit growth, we looked at this earlier, but you can see a much faster growth in LA than in California Metro and in the FQs in terms of both patients and visits. In the total visits per patient, as we talked about in a volume-based world, it's important, it's important or it drives profitability if people are doing more visits because of the way that we're reimbursed. So we just have been tracking this as we go through this transition period of a change from looking at volume to value. How is that impacting? So you can see that there's not a huge difference, but basically, across the state, we're seeing between 4.1 and 4.5 visits per patient. And I also just wanted to point out, I think this might be my last slide, looking at the insurance. It's really interesting to see that for all three areas have about the same number of Medi-Cal patients as a percent of total patients, so about 2/3, between 64 and 65%. But LA has a much higher percentage of uninsured patients, and obviously that's going to drive its operating model and its profit margins and so forth. So it has 27% uninsured compared to California Metro 22 and California overall 18. But still, LA has over the last couple of years really improved its margins considerably, despite that kind of disparity in uninsured rate. Oh, and yes, I forgot this was, I think, my very last slide before I give it to Jonathan, is just looking at, this really, I think, surprised a lot of people when we looked at this. Looking at, on the right-hand side, we look at the LA median in terms of how much of the composition of total visits is medical. It's 78%, with 8% of total visits being dental. Whereas if you look in the middle at California Metro, it's 62% medical and 15% dental, and then there's a big portion enabling and mental health. And then across the state, it's 72% medical and 14% dental. So this has been, somewhat enlightening to see how much smaller the dental percentage is in LA. And again, we're talking about ways to, help increase and meet market needs and capacity issues there, as well as do it most effectively. And that's it for me. So Kaylee, if you could turn it over to Jonathan, please. Thank you.
Kaylee, I'm assuming you can still roll us through the slides. Thank you, Susan. That's a great deal of very important information. And then now we're going to look at how we apply that to not only your organization and your association, but, if you remember that wisdom triangle, move it from the data and information to actually understanding and wisdom. There we go. So we're going to just take a couple of screenshots of what we call the performance evaluation profile. Many, if not all of you, have received this for your organization in an aggregate form. It has a lot more, analysis of the information that Susan has just provided us. So again, we're just going to look at some screenshots and see how this is kind of set up for you. So the first one right here, we're looking at a peer comparison. And again, this is a sample. None of these numbers you really equate to you or any real health center. We've got here where we compare an XYZ health center with the state and the national. Again, as Susan presented in her information, we're able to kind of carve this up and present it in the most appropriate formats and the most appropriate peer comparisons, whether it's California Metro or a statewide or some other region. We're on a statewide basis, we're actually doing some Medicaid versus non-Medicaid, which wouldn't really apply in this case. So you can see here that we're looking at some of the medical visits, dental visits, just a payer mix comes into account here, really how large of an operation that you're looking at over time. And here we've got the financial dashboard, which very directly correlates with a lot of the metrics that Susan provided, a lot of the things that you're likely tracking over time, very familiar with, whether it's operating margin, to the little bit more complicated, the personnel-related expense, days and net patient receivables. When we started the program, we ran these tests throughout the region just to kind of see what was similar, what kind of flags were being raised, both good green flags as well as possibly some yellow flags of concern. So when we ran these, again, it really gave us an indication of how the health centers across the industry were doing and really drove what the content would be and what type of training we would provide. And then the productivity dashboard, again, looking at some of the physicians and mid-levels and dental providers here, again, trending over time in an appropriate comparison group. This one's a little different. This is the operations and utilization dashboard. We've talked about this a couple of times, and we may touch on it again this afternoon, to where, traditionally, the way the health center model has been constructed, encouraged, and incentivized, it really was about patient visits and looking at your revenue and making sure they cover costs and looking at that operating margin. Here, one of the most important things we'll talk about is during the transition and payment reform, about how, while you certainly want to keep an eye on revenues, you certainly want to start looking at a little more closely the cost and what consists of those costs, whether it's by patient, whether it's by site, whether it's even drilled down to by visit. So here we're looking at some of those trends over time, as well as those patient and visit growth rates that Susan mentioned earlier. And then the payer mix dashboard, I think this was one of the last slides that Susan had. Really just trying to take a look at over time how Medicaid expansion and your own personal outreach has kind of affected your payer mix. Certainly when we start looking at financial projections and how you're reimbursed for those patients, this definitely comes into play. Whether or not we're evaluating the strength and the significance of your 330 grant, or how Medicaid and Medi-Cal eligibility is being determined. Again, this gives you a trend over time of how it's being, sorted out or weighted within your organization. And then why are we doing all this, right? We do a lot of this work, and then, we get the so what I certainly do it as well. So we're going to just take a quick peek at some of these evolving business models that really pertain to a lot of the California environment, a lot of this work we put together with you in mind. So this is one of my favorite pictures. I've always equated a lot of health center operations to a trapeze artist. You know, the transition from fee for service to a value-based reimbursement, and what does that look like? You know, a lot of us are hanging on a trapeze and we're comfortable with that, but we know at some point we're going to have to let go and grab the next one. And at what point does that happen? And certainly different organizations, depending on your resources, depending on your planning, your capacity, that can lead to a level of anxiety. And so a lot of the AFS is really to not only look at the real numbers, but to kind of help you through this change management. And here where we talk about a really good visual, and you may have seen this before, talking about that shift from fee-for-service to value-based reimbursement. We're in that revenue transition period right now. We're really not sure, you know, if it's going to be accelerated under the current administration or if it's on hold. Who really is pulling the strings? Is it HRSA? Is it the insurance companies? And so, again, there is a great deal of uncertainty. And, you know, for those of you that actually look and read your retirement brochures where it says, you know, the past performance doesn't always indicate future performance. And so a lot of the things that we've held fast and looked at as standardized and being able to project into the future, those are called into question. And so a lot of our scenario planning, our contingency planning really does come from this AFS program. Here, when, you know, we talk about some of the things that are shifting, you know, for fee for service, you look at volume, where value-based, it's outcomes. You know, you can certainly read these here, where quality is always a concern in a fee for service, but now it's a financial driver. It's an incentive to go forward, to balance not only productivity and quality, but, you know, looking at those costs and having sort of your revenue per patient or per indicator kind of locked in and known ahead of time. So then you become more of an efficient operation. You know, quite frankly, for me, believe it or not, I'm a little bit of an introvert. So standalone systems can thrive in a fee for service. You know what you're capable of. You just go out and do it. You don't necessarily need a lot of collaboration. Well, for you extroverts out there, you'll be happy to hear that the value-based environment, as you probably well know, collaboration is essential, not only between teams, between organizations, but between provider types. And now with the social determinants of health playing a significant portion of our new operations, collaboration outside our four walls. So again, looking at from managing those revenues to managing those costs continue to be important. You know, I like this. You know, when we talk about the incentives, changing from a fee for service and just seeing, you know, our patients in the door and how often we can see them and address various issues, various services. How can we add additional services for our existing patients? You know, these redesigned incentives under a value-based reimbursement, we're still trying to figure them out. The payers are still trying to figure them out. How do you actually charge? How do you reimburse? You know, what's the return on investment? You know, I think I've given this example before. You know, I've recently moved to Colorado. Well, I say recently, it's actually 2 years today. But when I got here, my new insurance company encouraged me to establish a primary care physician by sending me a gift card. This was new to me, where I'd come from. They just kind of waited for me to come in. So finding, you know, your patients, making sure they're engaged in your system and taking advantage of your programs to ensure those good outcomes are certainly going to be part of our MO going forward. You know, here, you know, you try to inject a little humor into a difficult situation. A path to payment, you can see here, it's a couple of squiggly lines. Hopefully we're able to straighten some of those out over time, and then we can actually start to judge speed and distance, if you will. So Susan, you know, gave those very prominent, very significant metrics earlier, and they really were around operating margin and personnel expenses, some of the productivity, how many patients are your providers seeing. Here, when we start looking at the value-based reimbursement, they're shifted a little bit. You can see here now that you've got some productivity at the top, rather at the bottom. You've got here the cost per visit, cost per patient. And then you look at medical support staff ratio, and we'll actually look at some of these for your your region in just a moment, but knowing that it's simply beyond how many patients your physicians can see. You know, I think under the patient-centered medical home model for years now, we've kind of transitioned into a patient care team. How can those be most effective? What are, you know, the size of your staff? And not only does that create more efficient operations, it provides more predictable operations. You're able to plan based upon that. And I know, you know, Capital Link, we work with a lot of you around capital projects. Knowing how many staff and what types of patients and how they work through your operation and that patient flow really determines what kind of facility, what size. And so it drives more than just, are you meeting your measurables today? It really does determine how you're going to operate in the near future. And here we've got one of those charts where we talk about medical services productivity. Here we're looking at the support staff ratio. And I know that, you know, it seems that the scale here from 1.8 up to 1.92 isn't that great. But when you think about the scale and the number of employees and the number of staff that we're actually comparing this to, you know, I think under the patient-centered medical home, there was a sudden tick up in 2012 to 13, kind of plateaued in 14 as people may have caught their breath and tried to evaluate what they had just done. And then a gradual increase. And we certainly have seen this across the board, that as, you know, different providers provide different services are different costs. And so we're still looking at building some of that capacity under our most efficient means. And something here, you know, just goes right along with it when we start looking at the medical patients per provider, FTE. We've seen this slow decline over time and a recent plateau. And I think, again, this reflects the changing care team pattern, looking at what constitutes a visit. You know, I've said a couple of times, not necessarily to HRSA, that, you know, I think the UDS, and certainly they're addressing a lot of this, the UDS certainly needs to be revisited under a lot of these different models, whether it be financial or operational, to make sure they're still capturing that relevant data. So when we start looking at non-traditional touches as new encounters, things of that nature, we may continue to see this productivity kind of bounce around, but knowing what it is and knowing how to operate not only helps you be efficient, but helps you negotiate those contracts with different types of payers. And again, why are we here? You know, this webinar, you've taken time out of your day to kind of look at some of these numbers, consider your participation in further trainings. And again, the key here is communication. You can see here in the cartoon an unfortunate incident. I can't say minor. I'm not the guy on the table that dropped. But, you know, knowing that communication is key. Again, not only between you and your immediate staff, but your different departments, your payers, certainly, you know, your PCAs and associations, as well as your supporters. And we real quickly, as we start to wrap this up, starting to look at some of the additional tools and trainings that have either come from your AFS program or something that Capital Link has developed just in support of you. Again, here we start looking at a revenue cycle toolkit for community health centers. And again, this is in addition to those benchmark toolkit that Susan mentioned earlier. Recognizing the need and the desire to talk more about revenue cycle management, further define it in order to improve it. We worked with the Los Angeles Clinics and Association to put together this toolkit. I think the next slide also. Yeah, so here we're talking about the revenue cycle management. Based upon that toolkit, we put together a series of trainings. And again, it's not just for the CFO, it's not just for the biller, but, you know, when we talk to clinicians, they're surprised at how much influence they have over the revenue cycle management. You know, every aspect of the organization. And here you can kind of see the cycle that a patient and a bill and a receivable may go through. So again, we don't want to, you know, just subtract certain folks from the overall team and then leave others. It's really good to have the entire team hearing the same thing at the same time so they can put it in context together. Here we, you know, based upon your numbers and some other national standards, some front-end sample metrics, you know, we're looking at the schedule occupancy rate, 95% capacity. pre-registration rate, which is great when you're looking at scheduling, greater than 98%, and then insurance verification rate, to where folks walk in the door and some of this information has already been taken care of, at greater than 98%. And again, this is based upon some of the metrics that we have seen across the country, working practices, as well as some of your operations. And again, these metrics that we're looking at now are included in that toolkit. Here we've got some of the back-end metrics. The percentages of claims billed electronically, 95%, days to claim submission, 2 days, and then the denial rate is less than 5%. So not only is this reflective of, the association and some of the efforts, but really those benchmarks we're trying to achieve. And when you're looking at your own operation, establishing cost per patient, per year, per site, what have you, knowing what some of these formulas and percentages are, do continue to drive that data from simply being data to an understanding. And then here we've got reduction in the no-show rate trainings. This is just some samples that we've gotten. Some of you may have seen some of our work around health metrics, who we collaborate with around provider productivity, and just showing how, a small change in these metrics can mean real change in your organization. A 1% reduction in no-shows, if you have 10,000 appointments annually, a net patient service revenue of $150 a visit. So I know probably some, if not all of you, probably see more appointments than that. So you can imagine the return on this effort would be even greater. But that would change 100 more visits per month, which is another 15,000 increase in revenue. If you're experiencing, a 3, 4, 5% operating margin, that, equates to real savings and real opportunity to put some resources aside. If you were to experience a 15% reduction, then you're looking at 450,000 increase in revenue. And that's really a change from struggling for payroll to being actually to build your day's cash on hand. This is something that we're working on now. We've emphasized the cost of your organization and identifying that. We're working on a cost of care analysis that, Susan may kick me under the table, that we hope to be able to provide and implement in our trainings with you over the year to really help you use the data you already have to determine what those costs might be, to help you develop those metrics and dashboards. So here, what does success look like? We're coming to the end of this particular webinar. You've got time and resources and teams and operations and patient satisfaction and patient outcomes and financial sustainability. These are all separate topics, but and you can advance the slide once, please. You can see here that they all lead to one another. Just like the wisdom triangle goes up, a lot of these continue to filter down through your operation. You can't subtract one without affecting the other. And so going into it with that mindset, being able to not only assess your organization with you, but be able to determine what factors would have the greatest impact. Now, if you get to the financial sustainability and all these other things are addressed and you're feeling pretty good, you can advance the slide one more time, please. Guess what? You get to start all over. But it's not always a bad thing. Certainly, if you have the time and the resources to sit down and plan, this is a never-ending cycle. I tell health centers that we work with all the time that we don't have the luxury of a finish line. The race isn't done at the end of the day. So certainly we want to continue this process and just continue helping you be an efficient organization. So I think that, yes. So while you've got the contact information here, we certainly want to, again, emphasize, in the handout section of the webinar, one of those 3 handouts is the application that is current. And again, the deadline is extended to next week, February 9th. I think, just mentioning for those of you that are new to the program, what these applications really do is provide you the opportunity to receive, not only the group trainings, but individual technical assistance. I think it's up to $10,000 that's fully subsidized through the association and its funders. For those of you that have gone through the AFS program, I think there's a 50% match. So every organization certainly has the opportunity to really, take advantage of these resources and these tools that have been put together. So I think we've got just a couple of minutes for any specific questions, not only about the Capital Link and, questions for the association, but certainly anything that we can address in the short term around the AFS program.
Feel free to type any questions into the GoToWebinar question section.
And I often say I start discussions, I rarely are able to end them. So I know we probably stirred the pot with a few of you.
No questions so far.
Well, I'll go ahead and say this. For those of you, again, that have worked with the program before, the 4 contacts that you see on the screen, we've been on site several times, worked with several of you. It's great. For those of you that are new, feel free to reach out to one of us to discuss an aspect of your application. Again, my name is Jonathan. I'm at the bottom left. Certainly, working through this program and looking at the menu of different technical assistance and helping you determine, what would be the most appropriate, talk about timelines, personalities, things of that nature.
Okay, so if there are no, oh, go ahead.
Oh, I'm sorry. I was just going to end with, for reference, Tony Skabinski is in California, so he's right there with you.
Perfect. I'm not seeing any questions, so anything else, final thoughts from Jonathan or Susan?
Just appreciate your time and hope to see an application from each of you and enjoy working.
Thank you so much.
Great. Thank you so much to our presenters. Great. Thank you. And yeah, no problem. And as you exit the webinar, a short evaluation should pop up for you. So if you would mind taking a moment to complete that. And like I said, I'll be sending out the materials in the next day or so. Thanks to everyone, and we'll look forward to seeing you hopefully in March at the AFS 200 series.
Thanks, Kaylee. Bye-bye.